everyone. Thank you for joining our Psychopharmacology consultation line today with Dr. Matcheri Keshavan and Dr. Salman. I'll be turning things over to them shortly, but first I'd like to review a few housekeeping items with you all. Please remember to mute your computer speakers if you are calling in via phone. The computer speakers can be muted through Adobe Connect by pressing on the green horn above the presenter's pods. This consultation line is being recorded and will be available for viewing at a later time on the MHTTC website. The PowerPoint slides and any additional resources discussed today will be available later today as well. During the presentation, if you have any technical difficulties or questions about the topic, you can use the chat and questions box down on the bottom left. To reach us after the webinar, you can email newengland@mhttcnetwork.org. And with that, it's my pleasure to announce our speakers today, Dr. Keshavan and Dr. Salman.
Hi, good morning. This is Matcheri Keshavan. I'm a psychiatrist and currently the head of the Department of Psychiatry at Beth Israel Deaconess Medical Center, Harvard Medical School. I also have the pleasure of having with me Professor Salman, who is a well-known psychopharmacologist around the world. And so he has written a textbook on geriatric psychopharmacology, but he's a broadly experienced and knowledgeable psychopharmacologist for all aspects of psychopharmacology. Now, let me briefly say what our goals here in these consultation lines are. This is, as Rachel said, a part of the services provided by the SAMHSA-funded Mental Health Technical Transfer Center, and our service goal here is to make available expertise in evidence-based psychiatric treatments across a range of serious mental illness issues. And we have taken it as our goal to bring psychopharmacological expertise to clinicians across New England that may have one or other question from their practice to pose to this group. Of course, in an anonymous way, you could ask about your patients, or general questions about psychopharmacological practice in your day-to-day life. And we typically have one or other topic that is kind of a more central focus for these 1-hour discussions. But we are also open to discussing other topics as may come up during this conversation. So for today, we had suggested the possible topic of geriatric psychopharmacology, given that Professor Salman is an expert around that area. But we did not get any questions from any of the audience on that particular topic, but a couple of questions came up in the area of generally psychopharmacology of early course psychotic patients. So we could start off with that. And today, to that end, I put a few slides here together on the psychopharmacological treatment of first episode psychosis. Because the question that was asked was a very good one, and I'll read that out. And as we go through these slides, as we go through this topic, you may have other questions, and please put them in your text box, and we will be able to see those questions and take them up as they come. So the question that was asked, posed to us, was the following. Is there a tension between the two fundamental approaches to that drive first episode psychosis pharmacology clinical practice? On the one hand, we want to aggressively reduce the duration of untreated psychosis because being psychotic is cytotoxic. On the other hand, we encourage patients to learn about managing their illness and to consider pharmacology as an important part of treatment, but not the most important. So this is an extremely interesting and important question. It really gets to the heart of psychopharmacology of the early course of psychosis. So what I thought I would do is simply give you all an overview first of what the current state of the art in the psychopharmacology of first episode psychosis, and at the end I will get to the question as to whether continuing untreated psychosis is indeed neurotoxic or cytotoxic and so forth, because that's an ongoing debate in the field. and then Dr. Salman may give some of his thoughts as well on any aspect of what I'm going to talk about. And Carl, please feel free to stop me at any point and jump in. So here is my first slide, and let me see how I move to the second one here. So, okay. So first of all, I wanted to place in perspective what goes on in the real world in terms of psychopharmacological practice. And here is a study done by Delbert Robinson. He looked at the practice of psychopharmacology in early course psychosis at the beginning of an important study that he was involved with called the RAISE study. He looked at how many problematic psychopharmacological practices are out there, and how often do people practice exactly as the state-of-art, standard guidelines are. What he found was that in 40% of people there was some kind of problematic practice, and in about 30% there was often a high dose of the medicines that was used, such as olanzapine. And in about 35%, antidepressants were used without an indication. And in about 25%, there were multiple antipsychotics. Polypharmacy was used. And in about 15% or 10%, between 10 and 15%, there were psychotropic medications prescribed, but no antipsychotic for patients with psychosis. And in about 10%, there was too high a dose of antipsychotic prescribed in the first psychotic episode. In a small number, like around 2%, stimulants were prescribed in psychopharmacological treatment of first episode psychosis. So as you see here, polypharmacy and high and inappropriate dose of antidepressants and inappropriate use of antidepressants are among the common practices.
I might interject that here at the Mass Mental Health Center, where we treat and see severely ill patients with psychotic disorders, almost all the patients are on more than one antipsychotic, and some are on as many as 3 or 4. And a survey done in Massachusetts about 5 years ago by the Department of Mental Health determined that about 90% of patients with schizophrenia in Massachusetts were on more than one antipsychotic. This, as we will discuss, makes very little psychopharmacology sense, since all the drugs share the same pharmacologic profile, although they differ with side effects.
Thank you, Carl. And what you point out highlights the fact that what you see in this slide may be a little bit unrepresentative of what happens in the general practice of psychopharmacology in serious mental illness. What Delbert Robinson did was to survey a set of clinics for patients in the early course of psychosis, but not in a general adult psychiatry population. So this problem of polypharmacy and use of overdose of medications is even more common in general psychiatric practice, is what you indicate.
Right.
Now, so I put together here, and Carl and I have written about this in the various ways, of a number of general principles of good prescribing, and I'm going to take you through those. And you can remember them as the 10 commandments, the 10 C's, if you will. The first of that is use of pharmacological treatment as one-off, not the only or not the main treatment approach. In fact, this gets to the fundamental question that was asked to us. Psychopharmacology is one of several aspects of treatment which should be addressed in a coordinated fashion in a team, multidisciplinary team, whether it is the early course of psychosis or whether it is someone with a more chronic illness. So this is an important principle. The second principle is to develop an adequate, optimal therapeutic alliance, connecting with the patient and making sure that the patient understands what your goals are, what the treatment team goals are, and then obtain appropriate agreement. I mean, not necessarily a written informed consent, but an agreement and a therapeutic alliance and contract. The third thing is that good psychopharmacological practice always happens in the context of good diagnosis, a comprehensive assessment, a history of prior psychopharmacological treatments, what has worked, what has not worked, and so forth. The right choice of medications is critically important and has to be determined based on both what the patient is likely to respond to and what side effects the patients are likely to be averse to. The choice of the right dose and the right duration are important principles. Making sure that the patient adheres to the treatment, complies with the treatment is important. And making sure that the decision about pharmacological decisions are made in a shared manner. Collaborative decision making is a critical piece. Addressing comorbidity is critically important. Monitoring and preventing side effects is critically important. And of course, we are not gods. We always need a second opinion. And when we get stuck, we should always consult. And there is a 11th one there, I would say, chart it. Always document what you do. Carl, you want to add anything?
Well, this is a wonderful list. I think the umbrella for good prescribing, underneath which all of these factors are important, but the umbrella is to understand the patient and what they are experiencing and what is the context of their psychosis. It's not that they just have a list of DSM symptoms and that we're treating the symptoms. This is not like pneumonia in which you're going to give an antibiotic, or diabetes in which you're going to correct the insulin problem. This is a problem of a human being who has an illness that is usually relevant to some aspect of their life, even though there may be a biological and genetic underpinning. And to understand that and understand this context will help in building these 10 commandments, because the patient will feel better understood and more trusting of you if you really can communicate to them that you're interested in them as a person as well as in their symptoms.
Thank you, Carl. So I mentioned about coordinated specialty care. So, what we here at Mass Mental Health Center have been focusing in the last several years is the concept of coordinated specialty care. Any good treatment, whether it is in the early course psychosis patients or more severely chronic mentally ill population, is best delivered in the context of a multidisciplinary, multi-element therapeutic environment, which include psychopharmacology, of course, as a critical piece, but also individual psychotherapy, peer support, family-based treatment, cognitive remediation, integrated medical and behavioral health care, supported employment and education, as well as substance abuse treatment. And psychopharmacology is an important piece of it and should be integrated with all of those. For example, the prescriber needs to talk to the therapist about the psychotherapeutic issues, about the other approaches to intervention like cognitive remediation, CBT, and so forth, with the social workers, case managers, about peer support, about supported employment and education, and about integration with primary health care by interacting with the primary care physician, and also with the substance abuse counselors. So the prescriber is likely to get tremendously rich input from all of these team members, as well as from the patient and family, guiding the distinct steps of psychopharmacological treatment. In terms of connecting and engaging with the patient, we deal with a population which are typically those with poor insight. they have dysfunctions in the very same parts of the brain, such as the prefrontal cortex, which also monitors oneself and one's own illness. And when that organ is not functioning, they tend to have poor insight and also have poor compliance with treatment. And how do we address the issue of engaging with people with serious mental illness? So the critical pieces are use terms that the patient can understand. Sometimes psychosis is a better term rather than schizophrenia, because often the diagnostic labels keep changing. Psychoeducation is important, tailoring the educations to individuals' illness stage and ability to process, involving family members early and having them as part of the team and setting up open communication, correct misinformation such as, split brain disease or split mind, or that it is incurable and so forth. Teaching pathophysiology to the patients to the level, in words that best match their ability to understand. For example, going to the blackboard and explaining to them how dopamine is involved in cognition as well as in emotion and so forth. That can be very helpful. Emphasizing risk liability models, normalizing what they are experiencing, giving medical analogies like high blood pressure, asthma, and so forth. And also psychoeducation in people with serious mental illness. One time is not enough. Repetition is good. Emphasize interaction. So those are the key principles of psychoeducation in psychopharmacological practice. As I said, comprehensive assessment, which includes, and if the patient is coming to you for the first psychotic episode, make sure that you get a detailed history, rule out comorbid or antecedent medical illness, get all possible records. It may take weeks or months. Get family members' input, inquire about prior treatment response and prior side effects, make sure about compliance, inquire about the use of over-the-counter or alternative medications, obtain and review appropriate lab results as needed. For some of these medications can have risks like lithium or valproate and so forth, liver, kidney function, glucose and lipid profile. Antipsychotics, most atypical antipsychotics have, as I'm going to mention later, have negative effects on metabolic function, so getting a baseline workup with glucose, lipid profile, and so forth is a good thing. Anything you want to add, Carl?
Good.
Okay. And then choosing the right treatment is critical. Choosing an antipsychotic with a favorable side effect profile. At this time, with the exception of Clozapine, all antipsychotics generally have similar effects. The differences are in side effects. So choose an antipsychotic with the most likely favorable side effect profile and discuss with the patient. In first episode psychosis patients, they respond quite well with low doses. So in first episode psychosis patients, we prescribe doses of almost half of what we use in chronic multi-episode schizophrenia. First episode patients also are more sensitive to side effects. So monitor side effects closely, let them know what to expect, and then talk to them soon after, relatively soon after they start taking their medications. Monitor closely for medical comorbidities. Use patients' self-ratings, which can be quite helpful if your clinic has a standard practice of doing a BPRS or a DSM-5 symptom checklist. Those kinds of quantitative ratings can be quite good and useful for measurement-based care. Are second-generation antipsychotics better? Generally, studies have found second-generation antipsychotic drugs, with the exception of Clozapine, to be about similar to first-generation antipsychotic drugs, even though some studies do favor second-generation antipsychotic drugs. The basic principle is that second-generation antipsychotic drugs produce extrapyramidal side effects less likely than the first generation or the so-called atypical antipsychotic drugs at therapeutic doses. So in this kind of graphic, what you see here in dashed lines are atypical antipsychotic drugs. So even in the therapeutic dose, even until you go to very high doses, drugs like risperidone do not produce extrapyramidal side effects. Whereas typical antipsychotic drugs like haloperidol, even when they are beginning to look slightly better, they are already showing Parkinsonian-like side effects. So again, just to highlight those points, the first generation or typical antipsychotic drugs are effective with positive symptoms, have a relatively low risk of weight gain, especially with drugs like haloperidol and fluphenazine, even though chlorpromazine can make people put on weight. Whereas the disadvantages of first generation antipsychotic drugs are mainly the extrapyramidal syndromes, Parkinsonism, akathisia, tremors, and so forth, and prolactin elevations are a significant problem. With the second generation or the atypical antipsychotic drugs, they are also equally effective, less likely to elevate prolactin with the exception of risperidone, less likely to cause extrapyramidal side effects. Again, some medicines like risperidone do cause extrapyramidal side effects in higher doses. But the majority of atypical antipsychotic drugs, with the exception of some recent ones, they all cause some weight gain, increased risk of metabolic syndrome, and the more recent ones tend to be expensive. Some of them are off patent and not as expensive. But you want to comment on this?
Yes, I do. I want to, excuse me, I want to add a comment about the prolactin elevation. Since we're talking about first episode psychosis, we're talking about young people, often in their adolescence or late adolescence or early adulthood, ages 15 to 21, 22. But when one gives a potent dopamine D2 blocking drug to a young person, the prolactin elevation can produce very, very unfortunate side effects. Young boys in their adolescence begin to grow breasts, and young girls begin to lose their menstrual regularity. These are difficult to reverse when the drugs are changed or discontinued. And so it becomes a social embarrassment and a physical sense of shame for a young boy who can't wear T-shirts or can't go swimming. I can't go to the gymnasium in high school. And for the young girl who suddenly feels a loss of a sense of her growing femininity. For that reason, we are now tending to recommend the second generation antipsychotics that are not intensive D2 blockers, so they don't increase the prolactin. And there are some people who really feel that the strong potency atypical antipsychotics, such as risperidone, really shouldn't be given to this young population at all.
Would you say that some drugs like aripiprazole or brexpiprazole might be better?
My direct answer to this question is based on our own philosophy here at Mass Mental Health Center, and the answer is yes.
Okay.
That is a first choice atypical antipsychotic for a first episode young patient. We would probably choose aripiprazole as the first choice.
Okay, thank you. So then the question people ask is, what is the first choice you would make when you're seeing a patient for the first time with the first psychotic episode, and you have to decide as to which medicine is the one to use. But there's general agreement that Clozapine and olanzapine should not be first-line agents, even though olanzapine quite often is. It's also recommended in RAISE, one of the recent major studies that clotrimazine and haloperidol should be second-line agents due to the side effects. In the RAISE study, first-line agents are the remaining medications with relevant data such as aripiprazole, quetiapine, risperidone, ziprasidone, and so forth. But again, these are general guidelines, but in most situations, the clinician makes a decision in collaboration with the patient using a shared decision approach by presenting information to the patient about the efficacy and side effect issues and so forth. So these are broad guidelines.
I agree.
So as I said earlier, the conventional and atypical antipsychotic drugs clearly differ in their side effects, and I put here the standard conventional drug that is most frequently used, haloperidol, on the left, and the other atypicals, ziprasidone, aripiprazole, asenapine, iloperidone, racidone, risperidone, paliperidone, quetiapine, clozapine, and olanzapine to the right side of this slide. What you see here in orange are the side effects. So extrapyramidal side effects are most likely in first-generation drugs like haloperidol, whereas the metabolic syndrome and hypotension and sedation, weight gain, are more common in the atypical drugs. They are most common with the clozapine and olanzapine, and moderately common with risperidone, paliperidone, and quetiapine. And a number of the middle ones, where there is no color, might be relatively less. Even though they all have side effects, they may be relatively more neutral as far as metabolic syndrome and extrapyramidal side effects are concerned. I'll skip this slide, which is complicated slide on receptor binding affinity, just to point out that the low dose medications tend to be the ones that have high affinity, and that's why you need a lower dose. And I mentioned about the important principle of using the right dose and the right duration. As I said before, first episode patients may respond to long monotherapy trials of antipsychotic drugs. Polypharmacy is typically not needed in first episode patients. Antipsychotic doses that are about a half of what are used in chronic patients is often sufficient to obtain a therapeutic response. And studies have shown that using an antipsychotic drug like olanzapine or risperidone for about at least 16 weeks is likely to show benefit with monotherapy in the majority of patients in first episode psychosis. Cumulative response rates increase steadily every study week until the end of the trial. So don't give up too soon is the main point. The cumulative response rate is about 40% by week 8 and around 60% by week 16.
I would like to emphasize what Kesh has just said about don't give up. These drugs, whether they're first generation or second generation, take a long time to produce a meaningful clinical response. And one of the reasons that I think we're in the era of polypharmacy is that clinicians and the patient and families may become impatient that the patient is not responding or not responding quickly enough, so they add another drug or they raise the dose too high. In fact, these drugs will work, and they work quite nicely if you can wait long enough. That requires working with the patient and the family and the social context. But the drug itself can work, and this is partly due to the slow effect of these drugs on the brain function, particularly the dorsolateral prefrontal cortex. We know from the work with Clozapine, for example, that sometimes you don't see a meaningful response until about 6 months and occasionally a year. But at that point, the response becomes meaningful to both the patient as well as to us. So don't quit or don't give up too early.
Yeah, so it's the same point. In the majority of studies, there are good responses, like up to 60% within the first few weeks already. The other important principle is to make sure that you ensure that the patient is taking the medication. Studies have shown that the relapse risk goes up dramatically high with non-compliance with medications in the early course of psychosis. A small number of patients do not relapse after antipsychotic discontinuation, but that's a very small number, and we don't know how to predict who they are. So some people have argued that you shouldn't be giving these medications for too long, and that you should be giving them in very low doses and so on. So there are some reasons to argue in that way, and I'll come to that point again a bit later. Some people argue that in the long run, patients may not need antipsychotic drugs and so forth. That's somewhat of a debatable point, but my own experience, and I look to Carl Salman's viewpoint on this as well, I have made too many mistakes by taking the antipsychotic drugs off too soon. And if you do take them off, do so extremely slowly and extremely carefully with careful monitoring. So in the majority of patients, continued maintenance antipsychotic drug may become necessary because of relapses. And this is a slide showing relapse rates for discontinuation versus maintenance treatment in patients with early course schizophrenia.
So I do have some comments to make, Kesh. First of all, to emphasize that this is a disease with a very high likelihood of relapse if treatment is discontinued. And from a clinician's point of view, when patients relapse, the retreatment is harder. And the more relapses, the harder it gets. Also, Nancy Andreasen has suggested that relapse is associated with loss of gray cells in the cortex, and that some of the shrinkage of cortical matter may be due to these on and off phenomenon of treatment and then relapse, treatment and relapse. So there's every reason to encourage the patient and the family and the social context to maintain patience. Now, there are a few patients who may do well without medication once they've been stable for long periods of time. There's not much data on that. There's some clinical experience. The Vermont group many years ago showed that this was possible, and some of the early British work has shown some of this was possible. The experiment out in San Francisco with the Soteria House, where patients were treated without medication, ultimately did not work out. Initially it looked very positive, but over the long run these patients relapsed and were quite sick. I personally have actually been able to get a patient off all antipsychotics, but it took me more than a year. And this particular patient had a very supportive family who took care of her and watched her and helped her with her social environment. And gradually, as the drugs were withdrawn, usually by maybe 1% a week, it took me a full year to get her off. But it made a big difference, and she did very well after that. Lost a lot of weight, her acne went away, her hair got better, she went back to school, finished her degree, met a young man, got married, had a baby, and named him Carl. So I thought that was a pretty good result. But that was one patient. I would not say that this is the general rule.
Yeah. So, I'll tell you a story of one patient that I was able to do that, but then that patient taught me a lesson. So this was a young lady in her 30s. She developed psychosis. Very well-educated nutritionist, and she responded beautifully with just 2 milligrams of risperidone. I saw her for a couple of years, and then she moved away to another state, and then I had very gradually dropped the dose to around half a milligram, and had seen her for about another 6 months with no medication. She was doing just fine. So she left the state, and I lost contact with her, and 4 years later I got a call from her from an airport somewhere in the country, saying, Doc, I need that risperidone again. I'm hearing voices coming from the radiators and from the fans and so forth. So the point is, even those who do extremely well under stress could relapse. The reason that saved her was she had maintained some kind of a connection with me and had kept my telephone number with her as an insurance policy. And so because of that, so I was able to call in a prescription to the airport, get her to start taking the medicine, and she recompensated quite quickly.
I have one more illustrative example. We had a patient here at Mass General who had terrible psychosis, and over the period of treatment responded very well to antipsychotics. So well that he was discharged, was able to live alone, go back to school, and ultimately get a job. And about a year later, he came to see me as a follow-up. And he was not psychotic at all, and it was quite remarkable how well he was, until he told me that, in fact, inside he was really still very crazy. It's just that he had learned how to comport himself in a social setting so that he looked normal, and but so that he was saying that the drugs helped him in some way, but they didn't actually fix the psychosis. And I believe what actually happened here was that the drugs affected the positive symptoms in the frontal lobes, the dorsolateral prefrontal cortex, so that he learned the better judgment about social appropriate behavior, and that he should not talk about all of the crazy thoughts that he had in his mind. He should, act like everybody else and do very well. And he did very well. Another patient, this was not one of my patients, so I think it's a true story or not, but he was he had chronic auditory hallucinations, which the medications didn't help at all. And so he would be walking down the street talking to these hallucinations, and people would stare at him, and he was aware that he got these very odd looks. So he went and he bought an iPhone and put earplugs in his ears, and then walked down the street talking to his hallucinations, but it looked like he was talking to the telephone, so nobody stared at him anymore.
Fascinating. Thank you, Carl. That was a very good story. So just I want to stop here to ask if people are trying to put questions in here. I don't see any questions. Are there any technical problems you're experiencing? We would have some time to answer any questions that you might have. So please, write in any questions that you might have. But we can keep going until we see the next question.
I would ask a question of the participants.
Yes, go ahead.
If you use polypharmacy, what reasons do you have, what reasons do you give yourself to justify using two drugs? The most typical rationalization is that the atypical drugs are relatively weaker D2 blockers, so that they are relatively weaker treatments for serious positive symptoms. But if you add a strong D2 blocker, let's say haloperidol or a drug like that, to the atypical, you will get better treatment of these serious positive symptoms while getting the benefits of the atypical antipsychotic. And that may be true, because some patients who are very, very sick really need very strong D2 blocking. And I'm wondering whether any of the listeners this morning have had that experience, and what does that tell us about the possibility that some kinds of polypharmacy for some patients might actually be reasonable. The pharmacologic problem is when you add a first-generation drug, you basically lose all the benefits of the second-generation drug, because the strong dopamine blocking overrides the serotonin effect of the atypical drug, which is the main advantage of the atypical drugs, that they have less dopamine D2 blocking because they have a serotonin, an anti-serotonin effect. So that might wipe out the benefits, but at the same time, if the patient gets better without a lot of side effects, that might not be so bad. And I'm just wondering if there's anybody who's had this experience and what you think about my thoughts.
Yeah, thank you, Carl. So we'll see what the listeners experience here on that important topic. So this slide, which you've been seeing for some time, basically summarizes the key reasons for noncompliance, which include lack of efficacy, side effects, too complex a regime, expensive, poor treatment alliance, cultural and family barriers, poor insight, stigma, and also sometimes people don't take medicines because they're already feeling that they're better, and so just because the symptoms are gone away means that they are cured, and often they stop medications because of that. Or the grandiosity, I can solve all problems myself, or even cognitive impairment, forgetting to take the medicine could lead to non-compliance. So all of the opposite of those things are what lead to better compliance, effective medicines, safe medicines, simple regime, inexpensive, good relationship with the doctors, good supervision, good insight, good family support, acceptance of the illness, awareness of the severity and the consequences of the illness, and so forth. So often the question comes up as to the use of a long-acting antipsychotic drug. And so talking to patients, it helps to discuss the potential benefits of long-acting antipsychotics, the fact that they don't have to remember to take the medicine every day. Overall, the dose could be reduced by giving long-acting drugs with more smooth blood levels. Also, the families have less trouble having to bargain every day with the patients about taking the medicines, and that argument could be taken off the table with monthly or once in 2 months kind of injections. And also, the clinicians can know about non-compliance much faster because of the patients not showing up for their injections and so forth. So detection of non-compliance is easier. The other important question that keeps coming up, and we talked about that a little bit, is always patients ask us at the end of a year or two, when can I go off the medication, doc? So in most situations, the approach to take is to, first of all, find out why they want to discontinue the medications. Are they experiencing any side effects? review with the patient the risks of discontinuation versus the benefits of discontinuation, involve the family in the discussion. If finally you need to move in that path, reduce the dose. In any case, getting the dose to a maintenance minimum effective dose is always a good idea. Develop a therapeutic alliance and a contact with the patient for continued treatment for a specified period and periodically revisit this. If patient insists, consider very gradual discontinuation, maybe even like 10% every visit. Educate them about early warning signs of relapse. Have them carry a sample of rescue medication if in case symptoms come back, and also maintain a therapeutic relationship at all times.
I would just say that 10% a visit is too fast. I would do it even slower.
Yeah. Well, it depends on how frequent the visits are.
Yeah.
We in maintenance patients, we often see them once every 2 months, once every 3 months, and that's where I have tried the 10% approach. But sometimes it could be slower than that. So the risk of psychotic relapse is quite high, as I said before. Enhancing compliance requires understanding what causes the non-compliance, whether it is a refusal of medication, whether it is lack of efficacy of the medicines, whether it is side effects, whether it is missing or forgetting to take the medicines, or total refusal of medications. So the approaches are different. We have to pay careful attention to efficacy and side effects. And there are many clues to remember that we try to educate patients about. Sometimes, pill boxes, alarm watches, phone call reminders, long-acting injections are useful, and so forth. By the way, these slides will be available for you. So if I have gone too fast, you'll still have access to these slides. I said before that decision-making done in a collaborative way, shared decision-making with giving autonomy to the patient to the extent possible and letting them give their input is always a good idea. Clozapine is an important contribution to the field. We have had clozapine for some decades now. It's still not used, in my opinion, often enough, because there are side effects and many clinicians are reluctant to start patients on clozapine because of the problems of having to get a monthly blood test, initially weekly, and also the problems of weight gain and myocarditis and seizure risk and so forth. But in some patients, it can be a lifesaver. It can make a dramatic change in people's lives. And interestingly, even though clozapine has so many side effects, studies have shown that mortality is reduced by clozapine in schizophrenia, not increased. And also clozapine has some secondary benefits on substance abuse kind of issues and reduces suicide risk. So consider clozapine in treatment-resistant patients. And many patients may become treatment-resistant even early on in the illness. In the first psychotic episode, within a year or two, you might know that the person is not responding to clozapine. So considering clozapine in first episode patients is a good idea, even though the data available are kind of small.
I think anybody who is listening and watching to us already knows this, but the general recommendations would be if a patient has failed on a number of antipsychotics and they have not tried clozapine, they should have a trial of clozapine. And if it was a family member of mine, I would feel that myself. That at some point or another, if somebody's not getting better or not getting better enough, I might try them on clozapine and then try to help with the side effects as we go along.
Right. So the eighth commandment is check for side effects and monitor side effects. And for patients with the early course of psychosis, when you are starting antipsychotics for the first time, a start low, go slow strategy is always useful. And reduce the dose as needed. Once the patient is stabilized, consider switching antipsychotics if there are side effects, or use side effect medications as needed. Comorbidities are common, as you see here. Almost 50% have dyslipidemia. About 50% of patients smoke in the first episode psychosis population. And high blood pressure is seen in about 10 to 15% of patients. Fortunately, in the first episode psychosis patients, diabetes is around 5%, 2 to 5%, but it goes up as illness becomes more chronic, as they gain weight. And also metabolic syndrome is small to begin with, but builds up over the course of time. Depressive symptoms are also common and have to be considered. Often they are secondary to negative symptoms or Parkinsonian side effects. But depression could be also part of the schizophrenic illness itself. And adjunctive antidepressants can be useful, but should be used carefully. And treating patients with only antidepressants without antipsychotics can have a risk of triggering relapse. Substance abuse is very common and increasing with the liberalization of cannabis. Alcohol and other drugs are also common and should be considered.
I'm sure that most clinicians who are watching this already know about the increased risk of becoming psychotic when some adolescents smoke marijuana or just take tetrahydrocannabinol. Now, not all adolescents do, of course. In fact, it's probably a minority. But when it happens, it is a severe psychosis that is very, very difficult to treat. So I've met with many, many young people, and I've tried to tell them this, and of course, I'm always aware that they are nodding their heads and thanking me, but they're not paying any attention, and I understand that. But if there's if you're working with a young person and there's a family history of psychosis, that might suggest that this young person has the genetic vulnerability to become psychotic with cannabis, and one should take extra efforts to warn them about this and try to discourage use.
Thank you. Suicide risk is significant in psychosis population, especially in the first several years of the illness, unlike in depression where the risk keeps going up with age and in chronicity. And also, studies show that this suicide risk is high, particularly after discharge from the hospital. So make sure to inquire about suicidal thinking or behaviors, talk to family members, and provide needed supportive psychotherapy and CBT and so forth. Clozapine is worth considering in highly suicidal patients as well. So I will skip this very crowded slide, but basically to summarize that we know that early course of psychosis, psychopharmacology is quite effective even at lower doses. Side effects are more likely, but can be monitored and prevented. Maintenance treatment is worth bringing in early on itself, and clozapine is worth considering for treatment resistance early on in the illness. And there are a few guidelines for psychopharmacology in the early course of psychosis. We will have some papers that are placed on the website. But let me quickly address the one question that was asked, which is about whether psychosis is neurotoxic. What you see here is a slide from our own study, which is reflective of large literature that exists, showing that what you see here in these brains, the more red regions are those where cortical thickness, gray matter, is reduced. in patients with at high genetic risk for psychosis. But then if you go to people who are already in the prodromal phase of the illness, the gray matter losses become even more consistent, especially in those who convert to developing disorder. And the gray matter loss becomes even larger in patients in the early course of psychosis. So even before antipsychotics are administered, you already see gray matter loss. And it is a function of how long they have been ill with psychosis. The longer the duration of untreated psychosis, the worse is the gray matter loss. So there is good reason to think that continuing untreated psychosis can be bad for the brain. Whether it is neurotoxic, whether it causes cell loss, or whether it is simply synapse reductions, those are questions that are still being researched. But on the other hand, there is another line of research that has kind of stirred up some controversy. Andreassen's group published a paper showing that the longer people have been on antipsychotics, the worse is the gray matter loss, as you see in that slide on the top left. And adding to the controversy, one study, this has not been replicated to my knowledge, showed that if animals like monkeys were treated with haloperidol or risperidone, their gray matter volumes decreased. So this raised the question as to whether chronic treatment with antipsychotic drugs could actually be leading to some gray matter loss and so forth. But by contrast to the first paper by Beng Ho and Nancy Andreassen, subsequent papers by Nancy Andreassen showed that the degree of gray matter loss was related to the number of times they relapsed and how long they were in a relapse state, how long they were psychotic during the overall course of the illness, which suggests that what's happening, this finding of increased gray matter loss with chronic antipsychotic treatment is simply related to the fact that those who are on longer antipsychotic treatments are also chronically ill. They have a lot of illness. And in fact, this is related to the time that they spent being psychotic, being ill. So it's easy to blame the antipsychotic drugs, but the issue is not so clear. It's quite possible that chronic illness, not necessarily a psychosis, simply being chronically ill and sitting in the basement with social isolation and poverty of thinking to a disuse atrophy of the brain. If you don't use the brain enough, of course it atrophies. So it's not just medication-induced. It is probably not medication-induced. It's probably psychosis-related, and it's probably also related to negative symptoms. So it's important to treat them, not only with antipsychotics, but also with psychosocial rehabilitation, so that you improve their interaction with society, improve their functionality, and get them to start using their brains more. And that brings me to the other question that was asked. Is it risky to, let me read the question. We've got just one more minute, so this question was asked, second question. Am I irreversibly jeopardizing my patient's long-term cerebral function by letting them learn from experience? The answer is absolutely to the contrary. Long-term cerebral function is actually benefited from getting patients to use their experience-dependent brain plasticity. Of course, in a controlled way, so that they don't expose themselves to too much stress, but they need to interact.
But if this questionnaire is asking that in order to encourage their experience, they don't use medication, so the patient goes untreated pharmacologically in order to participate in the therapeutic programs, that's a high risk.
Yeah, that's a high risk. Yeah. I think we are at 11 o'clock. We're almost at the end. I'm assuming that there are no other questions. Rachel, do you want to say anything by way of wrapping up? But thank you both for on both of us, our behalf, I want to thank you all for your participation.
Yep, so you'll be receiving an evaluation form for this event right afterwards. In addition, we have a few upcoming events, and please feel free to register if you're interested. And thank you all for joining us today.
Bye.
Bye.